Thank you. Thank you so much. And so nice of you for this kind invitation and the very kind introduction. I'll be speaking about Indian phakic intraocular lenses, my experience. Mind you, this is not some kind of a promotional talk. We use the ICLs quite a lot. We started using the ICLs in 2004 and still use quite a lot of them. I would say it's about 50% ICL and 50% IPCL. And I think as far as Indian phakic IOLs are concerned, it's not just IPCL. There are also ICRL lenses. There are lenses available from Apasami. But our own experience has been more with the IPCL. So I'm essentially going to be confined to that. Mind you, ICL is also a great lens. And I think just like we offer imported and Indian intraocular lenses to our patients, similarly, you can have the spectrum of both these lenses. As far as the comparison between these two lenses is concerned, because I still consider ICL as the gold standard, the dioptric range in the ICL is somewhat smaller as far as the refractive correction is there. It's plus 10 to minus 18, while in IPCL you get almost from plus 15 to minus 30. And even for more extreme powers, you can request the company to customize them. Astigmatism, again, the range is a little higher. The material is Collamer as far as ICL, which is unique. And this is considered to be the most biocompatible material, though it's just a coating on the surface of the lens. Essentially, the lens itself is hydrophilic acrylic. As far as the IPCL is concerned, it's again hydrophilic acrylic, almost the same material as what they use for the intraocular lenses. This was one of the reasons I was initially reluctant to take up these lenses. But now, having used them for 7 to 8 years and seeing the quietness with these eyes react on our own personal experience, now I do not have hesitation in using these lenses. As far as the holes are concerned, which is extremely important for a communication between the anterior and the posterior to the lens, there are two paracentral holes in the ICL with a central hole. While in the case of IPCL, there are a few more. There are 4 in the paracentral region, 1 central hole of about 400 microns, and 2 holes over here, which are supposed to be coming superiorly under the lid margin. Because of these holes, both these lenses do not require any peripheral iridotomies. As far as ICL is concerned, there are 4 haptic pads. In IPCL, there are 6 haptic pads, which is supposed to give it even better stability. But personally, I have not felt that either of these lenses move that easily. And again, other differences are that when you come to toric ICLs, which are most often used, you have to dial them into place because they are not always 0, 180 degrees. But because IPCLs are more customized to the requirements of the patient, they can always be oriented in the 0, 180 degrees. The 360 micron is the size of the central hole, while it's a little larger in the case of IPCL. But I think both of them function equally well in creating an adequate communication. One of the most important aspects, especially when you're switching from one lens to the other, is that in the ICL, it's the leading right edge and the trailing left edge, which has a small mark over here. While in the case of IPCL, though it's not shown in this cartoon, you have a collar stud over here and over here. So it's the leading left edge and the trailing left edge, which has an indicator, and you have to be cognizant of this fact. ICLs are dispensed in BSS, while IPCL is dispensed in saline. So IPCL, even after implantation, may expand a little bit for the first 1 or 2 days. The actual vault of the lens is better just 2 days later. The loading is a little different as far as ICL is concerned. That's something you need to learn if you're picking it up initially. But as far as IPCLs are concerned, it's almost exactly similar to a plate haptic intraocular lens. So it's easy to get on with it. And as far as the sizing of these lenses is concerned, today we have more the ICL EVO available to us. These lenses are available in the 5mm range when it comes to the smaller, the higher powers, and 6.1 millimeters when it comes to higher powers. In the case of IPCL, the optics is slightly larger in the sense that it's about 5.75 millimeters beyond minus 14.5 diopters, and it's 6.2 millimeters when it comes to smaller powers less than 14.5 diopters. This is a significant advantage because especially these mesopic pupils in these young individuals tend to dilate, and having a larger optical diameter is obviously an advantage. And in case you want to custom make for specific large scotopic pupils, that's again possible by ordering to the companies without altering the overall diameter from 11 to 14 millimeters. Going on to a couple of videos, as you can see over here, that's an IPCL. You can see the 4 holes over here, the holes in this region, the central hole, which is 400 microns, the 6 pads which essentially act as a allow the accurate positioning of these lenses. And most often, we almost 70 to 75% of the lenses we use are toric lenses. And you can see the stud over here, which is in the leading left haptic, and in the stud over here, which is in the trailing left right haptic. And that's something you need for the orientation of these lenses. And this is an important factor that you do is to, when you are loading these lenses, you do not use any viscoelastic, but essentially use just saline. And this is dispensed in a sachet of saline, as you saw. You just pick it up like any hydrophilic plate haptic lens, intraocular lens, position them and make sure that they're tucked under the flanges. Then subsequently, some recommend that you just put a drop of viscoelastic, but I find that just using it under saline is quite good. You have to make sure that there is no haptic that's getting caught, and that's the loading that's completed. And usually it's at 180 degrees that you make the side ports, and that's a xylocaine that's being filled in so as to create a certain amount of intracameral anesthetic. This is a 2.2 millimeter incision that's being expanded to 3 millimeters. And this is a slightly older video that I'm showing now. And that's a HPMC that's being used. And that's the intraocular lens being injected inside. And you'd find that you, even after 7/8 of the lens is inside the eye, you still have control over the lens. And just in case you feel the lens is not opening up in the right way, then you can go ahead and withdraw the lens and re-inject it. And that's viscoelastic being injected in front. There are also excellent surgeons who do the entire introduction just under saline. That way the pain of removing viscoelastic is not there. But I'm more comfortable doing it under viscoelastic. Though initially it was HPMC, and as we see in a subsequent video, nowadays we use more of cohesive viscoelastic. And this is exact positioning of the lens that's being done. And in these, when you use a dispersive viscoelastic like this, removal of the viscoelastic is extremely important. And because the holes that are there, just retaining the aspiration cannula in front of the central hole itself allows you to evacuate the viscoelastic quite completely. This is a cataract case. Sometimes you might have come across a situation where you create a small nick like this on the anterior capsule. Obviously, this is a cataract case, I could deal with it. But if it had been a case of an ICL or an IPCL, that's the end of a case because the lens has been damaged. Because of, though it has not actually, I had not had this complication, because this complication is always possible, I have somewhat modified my technique today in the sense I do not preoperatively dilate. You can see it's a constricted pupil. I make the side port incision, just use saline to make the eyeball a little rigid and make the main port incision, which is using a 3 millimeter keratome. And then subsequently, I inject intracameral anesthetic with mydriatic. It creates an extremely good dilatation. Now it's cohesive viscoelastic, usually Helon that's going in. And you can see the dilatation that I get is extremely good. As good as what you would get with preoperative application of dilating drops. So essentially, I do not dilate them preoperatively because I feel that the iris cover on the lens gives you an adequate protection so that there is less chances of damaging the anterior capsule. And I use cohesive viscoelastic for introducing the lens. The advantage of that is that, as you would see subsequently, I do not even inject irrigation. The irrigation aspiration cannula is not even taken inside. While I am hydrating the central and the side port incision, the entire viscoelastic flows out just as a bolus. The moment viscoelastic starts flowing out, I know that the complete viscoelastic is out. And most often, I do not use any irrigation aspiration cannula inside at all. That's another, that gives you much better control. And you can see that this is actually hardly edited video. And just in about a couple of minutes, you are able to finish the surgery. Then I would just go on to our study, and we did a study with these lenses. And what you would say, this was done between August 2014 and May 2017. And 134 of them, say almost 80% of the lenses were toric IPCLs, where 20% were spherical. As you can see over here, most often the indication was myopia. A significant number of cases were keratoconus, where it was quite a stable keratoconus, either because of cross-linking or because the aging of the patient. Hyperopia was quite less. As far as the age distribution, like in any refractive surgery, 18 to 27 age group constituted 80% of our patients. And The sphere was up to minus 21 diopters with this IPCLs, the spherical equivalent, and even a higher powers is possible. The range of scale is up to 6 diopters. And the spherical equivalent, as you can see, is, can I take just about a minute more?
Yeah, please go ahead, sir.
Yeah, okay. The comparative data, as you can see, the excellent correction as far as the refractive outcome is concerned, not just at 6 weeks, but even at 6 months, you can see the mean sphere, the mean cylinder, the mean spherical equivalent was much less than 0.25 diopters, especially in this particular subset of cases that we have dealt with. And as you can see over here, the preoperative best corrected visual acuity to postoperative best corrected acuity at the end of 6 weeks, you can see that almost 90% of the patients, the uncorrected visual acuity was better than the preoperative best corrected visual acuity. In about 43 cases, that's because of the minification effect of the minus powered lenses is done away with. And that's something you experience with even after LASIK treatment. But because of the proximity to the nodal point, that's something you experience with the phakic intraocular lenses, even in higher grades. And this is the current kind of correction that was maintained even subsequently at 6 months interval. And there were a few cases where there was about a minus 1 diopter. And as I'll dwell with in subsequent slides, this was more in the keratoconus cases. As far as the safety itself was concerned, it was just only in one patient there was a one-line drop in the visual acuity. In all other cases, the best corrected visual acuity postoperatively was at least equivalent, if not better, than the preoperative. As far as rotation was concerned, 8 eyes required repositioning, and it was in 6 eyes it was less than 10 degrees, and 5 of these eyes which required repositioning were in the keratoconus group. These were some of the complications that we experienced, but all of them could be handled with. And IOL rotation is something that we do whenever we experience that the postoperative outcome is suboptimal. These are a couple of papers that we have published just with the IPCL 134 eyes, which says that it's a safe and effective treatment. And this is a comparison between ICL and IPCL, 119 eyes of IPCL and 203 eyes of ICL. And what we found was that the results were extremely good in both these categories. Thank you so much for your kind attention.